Okay, welcome to Part 4, Chapter 45. We're going to discuss seizure disorders. Caused by excessive and disorderly neuronal discharges in the brain is determined by the site of origin, most common neurologic dysfunction in children, and often a symptom of an underlying disease process. Intracranial could be epilepsy, congenital anomaly, birth injury, infection, trauma, degenerative disease, and vascular disorder. Extracranial, there's fever, heart disease, metabolic disorders, hypocalcemia, hypoglycemia, dehydration, and malnutrition. For toxic, we have anesthetics, drugs, and poisons. Acute symptomatic can be caused from head trauma or meningitis. Remote symptomatic could be due to prior brain injuries such as encephalitis or stroke. Cryptogenic, that's really no clear cause. And of course we have idiopathic, which is genetic in origin. Okay, let's talk about the different types of seizures. Regardless of the type of seizure, the basic mechanism is the same. Look at box 45-6 on page 1446 for etiology of seizures in children. I'm going to talk about a few of them. So you have a febrile seizure. This is a transient disorder of childhood. It affects approximately 2 to 5% of children. Usually occurs between the ages of 6 months and 3 years. It's rare after generally the age of 5. It's twice as frequent in boys. The cause is uncertain, but it can be caused by a viral infection. We have epilepsy seizure. There's 2 or more unprovoked seizures. It's caused by a variety of pathologic processes in the brain. Optimal treatment and prognosis require an accurate diagnosis and determination of the cause. Classification and clinical manifestations you can see in box 45-7 on page 1447 of your textbook. Generalized seizures. It involves both hemispheres without local onset. We have the tonic-clonic or the grand mal. There's 3 distinct phases. So we have partial seizures. These are local onset and involves a relatively small location of the brain. Counts for about 40%. Consciousness may be intact or slightly impaired, and they can have a simple or complex seizure. Then we have absence seizure. These are formally called petit mal seizures. Onsets between 4 and 12 years of age, more common in girls than boys. It is an abrupt onset. It's often mistaken for not paying attention or staring into space. You want to look at table 45-3 on page 1448 for comparison of seizures. Okay, remember I said there's phases of tonic-clonic seizures. Well, the child may have an aura, often report seeing things such as flashing lights or smelling funny smells like rotten eggs. The tonic phase may last 10 to 20 seconds. Clonic phase lasts about 30 seconds but can vary from a few seconds to 30 minutes or longer. Status epilepticus. It is a medical emergency that is associated with significant morbidity and mortality. Status epilepticus is defined as a continuous seizure lasting more than 30 minutes, or 2 or more seizures without full recovery of consciousness between any of them. In hospital management of status epilepticus includes IV administration of diazepam or lorazepam. If ineffective, phosphenytoin is administered followed by IV phenobarbital. In-home treatment includes buccal, midazolam, and rectal diazepam. You want to look at medication alerts on page 1450 of your textbook. Post-ictal phase. It's a state of recovery. The child may remain confused for several hours. You want to be sure to refer to box 45-7 on page 1447 of your textbook. Okay, neat. Safety alert, safety alert. You want to cushion the head, remove the glasses, loosen tight clothing, turn on their side, and keep airway clear. Note the time a seizure starts and the length of time it lasts. Don't put anything in their mouth and don't hold them down. As the seizure ends, offer help. Now we're going to talk about some diagnostic evaluation. Take a detailed history, including the type of seizure, the child's behavior during the event, and the child's age at onset, the time at which the seizure activity typically occurs. A complete physical and a neurological assessment should be completed. Look at box 45-8 on page 1451 of your textbook, General Observations of the Child During a Seizure. Lab studies can be done, such as a CMP and a CBC. A CT may be done to detect cerebral hemorrhage, infarctions, or gross malformations. An lumbar puncture may be done to rule out meningitis. And of course, an EEG is the most useful tool for diagnosing and evaluating seizure activity. All right, seizure management. Look at box 45-9 on page 1451. Review seizure precautions and nursing alert. The goal of therapy is to control seizures or reduce the frequency and severity. Discovery and correction of the cause is necessary if the seizure activity is a manifestation of an underlying disorder. So for management, we have drug therapy. Usually anti-epileptic drugs are used to raise the seizure threshold and prevent or decrease seizure recurrence. Complete control of seizures can be achieved in about 70-80% of all children with effective drug management. Now, of course, we have the serum drug levels that have to be periodically assessed. Dosage is typically increased as the child grows. The drug may be discontinually gradually over several weeks. After 2 years of complete seizure control in children with no risk factors older than 12 at onset and history of neonatal seizures, numerous seizures before control was achieved in the presence of a neurological dysfunction. Reoccurrence occurs in about 40% of children within 6 months of discontinuation. Then we have a ketogenic diet. That's high-fat, low-carb, adequate protein diet. It forces the body to use fat as the primary source of energy rather than glucose. It's a very rigorous diet. All food must be weighed and measured carefully. Early side effects of the diet include diarrhea, hypoglycemia, dehydration, ketoacidosis, and lethargy. Long-term side effects include dyslipidemia, renal stones, and poor growth. Over half of children on a ketogenic diet have greater than 50% reduction in seizure episodes. Vagus nerve stimulation requires an implantable device that reduces seizures in children who have not had effective control with drug therapy. It's used as an adjunct therapy in children age 12 and older with partial onset seizures. The patient or caregiver activate the device at the onset of a seizure using a magnet. Has no long-term adverse effects. Dyspnea, throat or neck pain, and a cough can occur during stimulation. Surgical therapy is indicated when seizures are determined to be caused by a hematoma or a tumor. Surgery is reserved for those with incapacitating refractory seizures. So prognosis. Most children who experience a second seizure will experience additional seizures. Children with epilepsy and a severe neurologic status are 22 more times likely to die than a child with epilepsy and a normal neurologic status. Mortality is associated with the frequency and severity of seizures. Long-term care requires physical care and ample education regarding drug therapy and importance of not stopping anti-epileptic drugs suddenly. Educate the child and family about epilepsy. Help them to develop coping strategies. Help parents to plan the administration times of the medications prescribed to maintain that adequate levels in the blood and to schedule them for convenient times to avoid disruptions of family routines if possible. Triggering factors should be carefully detailed and documented. The most common factors that may trigger seizures in children include, but are not limited to, emotional stress, sleep deprivation, fatigue, fever, and illness. 90% of patients with epilepsy recognize at least one additional trigger, and some patients have pattern or photosensitive epilepsy when seizures are precipitated by flashing lights. The treatment goal is living a normal life as possible. Now, when you look at cranial deformities, these are usually could be a suture and fontanelle ossification. Usually at 8 weeks of age, the posterior fontanelle closed. 6 months of age, the fibrous suture lines and an interlocking of the serrated edges. And then 18 months of age, we had the anterior fontanelle closed. After 12 years of age, sutures are unable to be separated by the increased intracranial pressure. Various types of cranial deformities are encountered early in infancy. We have craniosynostosis, is the closure of a suture before the expected time and inhibits perpendicular growth. This alteration of growth always produces a distortion of the head shape, with the underlying brain growth is normal. It's kind of pictured here. There is a small head with closed and normal shape is a result of a deficient brain growth. So prognosis. The majority of infants with craniosynostosis have normal brain development. Nursing care involves identifying children with deformities and refer them for further evaluation. Because there's no treatment or cure for children with microcephaly, care is directed towards assisting parents to learn to care for a child with brain damage. We're going to talk about hydrocephalus, caused by an imbalance in the production and absorption of cerebrospinal fluid or improper formation of ventricles. Causes pressure changes in the brain, results in an increase in head size. It's because there's an impaired absorption of CSF within the subarachnoid space, obstruction through the ventricular system. It's most commonly acquired by an obstruction, a sequelae of infections, perinatal hemorrhage, usually apparent in early infancy. Other causes include neoplasms, infection, trauma, often associated with myelomeningocele. Symptoms depend on site of obstruction, age at which it develops. Look at box 45-10. Review the clinical manifestations of hydrocephalus. So some of the classic signs are increase in size of head. Cranial sutures separate to accommodate the enlarging mass. The scalp is shiny. The veins are dilated. Non-communicating. There's an obstruction of CSF flow from the ventricles of the brain to the subarachnoid space, typically the result of a developmental malformation. Communicating. CSF is not obstructed in the ventricles, but is inadequately reabsorbed in the subarachnoid space. Diagnosis is made based on head circumference in addition to the results of other diagnostic tools used, which may include transillumination, echoencephalography, CT scan, MRI, and a ventricular tap or puncture. Okay, let's discuss management. So for treatment, we want relief of hydrocephalus. Medications are used to reduce production of CSF. Surgery may be possible to place a ventriculoperitoneal shunt, which is the treatment of choice. For pre-op, we have frequent head position changes to prevent skin breakdown. The head must be supported. It has to be supported at all times while being fed. Measure the head circumference along with other vital signs. Post-op, assess for signs of increased intracranial pressure. Protect from infection. Depress the shunt pump as ordered by the surgeon. Position dependent upon multiple factors. Assess and provide for pain control. Teach parents signs that indicate shunt malfunction may be occurring, and teach parents how to pump the shunt. Signs of shunt malfunction in the older child can include headache, lethargy, and changes in level of consciousness. Shunt infection. The greatest risk period is 1 to 2 months after shunt placement. Infections can include septicemia, bacterial endocarditis, wound infection, shunt nephritis, and meningitis. So for treatment, we would have a massive dose antibiotics or shunt removal. This concludes part 4 of chapter 45.